Vanakkam. As we all know, rheumatoid arthritis primarily involves the joints. But we also know that rheumatoid arthritis is a systemic inflammatory disorder and hence it also involves other organ systems. For example, it can involve the skin, it can involve the neurological system, the cardiac system, the lungs, and so on. So, before we learn about the arthritis problem in rheumatoid arthritis, I think we should know about the extra-articular manifestations of this disease, which may sometimes be very important and sometimes even fatal. In this video, we shall see these extra-articular manifestations, how they occur, why do they occur, and how do we treat them. It is important to learn the clinical features of rheumatoid arthritis per se, and for that we will have to learn the clinical presentations of arthritis, that is, the involvement of the joint and the associated structures like the tendons and soft tissues. But in rheumatoid arthritis, other systems can also be affected since it is a systemic disorder. The involvement of the other systems is known as the extra-articular manifestations, and it is these extra-articular manifestations that we are going to see in this video. The extra-articular manifestations of rheumatoid arthritis affect anywhere from 7% to 40% of rheumatoid arthritis patients based on various studies. Sometimes patients may present with these problems like skin nodules even before they develop the classical arthritis symptoms. And these extra-articular manifestations have significant morbidity and mortality. But do all patients with rheumatoid arthritis develop these extra-articular manifestations? The answer is no. There is a significant interplay between the clinical characteristics, the lab parameters like the rheumatoid factor positivity, the genetic predisposition of the patient, the environmental factors like smoking, and the medications that are being taken for the treatment of the condition of rheumatoid arthritis that determine whether the patient is going to develop these extra-articular manifestations, which can involve the eyes, the pleuropulmonary structures, the skin, the gastrointestinal system, the neurological system, cardiovascular system, the kidneys, generalized involvement like the Felty syndrome, and the haematological manifestations. We shall see the individual involvement of these systems in detail. First, the neurological manifestations. There are two common sites of rheumatoid arthritis involvement that may be associated with neurologic problems: the cervical spine and the peripheral nerves in the upper limb. All levels of the cervical spine may be involved, but the most severe areas that are involved will be the atlanto-occipital joint, the C0, C1, and the atlanto-axial joint, the C1, C2. In the cervical spine, the disease and its manifestation range from asymptomatic radiologic changes up to life-threatening situations with gross instability of the upper cervical spine. The inflammation process produces a so-called pannus formation with bone erosions. The ligaments subsequently weaken, leading to subluxation of the mentioned joints. This causes compression of the spinal cord, compromises the vertebral arteries and the spinal nerve roots, and may even provoke impingement of the brainstem. It is noted that up to 80% of patients with rheumatoid arthritis have cervical spine problems, and it tends to occur in long-standing disease, but it can start 2 years after the onset of the disease itself. An atlanto-axial interval, that is the distance between the anterior arch of C1 and the odontoid, of more than 3 mm in adults and 4.5 mm in children is pathologic. The spinal canal can also be compromised, and the risk for cord compression increases if the spinal canal is less than 14 mm in diameter, that is, the distance between the posterior arch of the C1 and the posterior aspect of the odontoid. Plain X-rays play a role in the assessment of rheumatoid cervical spine, especially in patients who are asymptomatic. The classic set of investigations, that is X-rays we need to order, are an AP and lateral view, a flexion extension functional view, and a transoral view of the odontoid. But plain X-rays cannot detect bone erosions. MRI of the cervical spine should be performed when there is a suspicion of unexplained neurologic deficits occurring in a patient with rheumatoid arthritis. And in patients with long-standing disease, and especially before any major surgical intervention, a cervical spine MRI should be performed to serve as a baseline. This may prevent complications from oral intubation, and in cases of confirmed deformity with neurologic deficits, surgical stabilization of the cervical spine should be performed because myelopathy can evolve rapidly and cause residual deficits. As far as the peripheral neuropathy involvement in rheumatoid arthritis is concerned, two types of involvement of the peripheral nerves can be seen: compression neuropathy and ischemic neuropathy. Compression neuropathy typically involves the median nerve in the carpal tunnel, and there is approximately a twofold increased risk of developing carpal tunnel syndrome in rheumatoid arthritis patients. And in these patients, the carpal tunnel syndrome, that is compression of the median nerve, is caused by flexor tenosynovitis of the tendons which also form a part of the carpal tunnel. The diagnosis of the carpal tunnel syndrome in rheumatoid arthritis patients can be made by clinical examination, nerve conduction studies, ultrasonogram, and MRI, which will reveal an increased signal in the nerve, increased bowing of the flexor retinaculum, and swelling or flattening of the median nerve. When a diagnosis of a carpal tunnel syndrome has been made in a patient with rheumatoid arthritis, if the patient has mild clinical signs and minimal tenosynovitis, a splinting and therapy would be the line of management. And if there are mild clinical signs but severe tenosynovitis, steroid injections will help. For full-blown clinical presentation with mild tenosynovitis, a carpal tunnel release is indicated, but if there is severe tenosynovitis involved, a carpal tunnel release with a tenosynovectomy must be done. If bony spurs are detected, excision of these bony spurs is also indicated. Compression neuropathy can also cause the cubital tunnel syndrome, which is involvement of the ulnar nerve at the elbow. And this compression is said to occur due to rheumatoid synovial cysts arising from the elbow joint. Compression neuropathy of the posterior interosseous nerve has also been reported, and it is said to occur due to forearm synovial cysts with nerve entrapment occurring at the arcade of Frosch. Besides the carpal tunnel syndrome, peripheral neurologic conditions in rheumatoid arthritis patients are rare. The surgeon should always consider cervical spine involvement if unclear neurologic signs are present. Due to development of new medications for treatment of rheumatoid arthritis, synovial induced compression neuropathies will be seen less frequently. The second type of peripheral neuropathy, that is ischemic neuropathy, is due to small vessel vasculitis involving the vasa vasorum of the nerves. This leads to ischemia of the nerve and demyelinization. It usually presents as mononeuritis, mononeuritis multiplex, multifocal sensory and motor neuropathy, and distal symmetric sensory neuropathy. The involvement of the skin in rheumatoid arthritis is also quite common, almost up to 20%. It is believed to occur mainly in rheumatoid factor positive patients, and when it does occur, it is supposed to portend severe extra-articular manifestations in early rheumatoid arthritis. The classic skin manifestation is the rheumatoid nodule. It consists of subcutaneous nodules which occur typically on the extensor surfaces, especially where there is pressure involvement, like the upper forearm and elbow. They may be hard to sometimes soft. They may be movable and sometimes attached to the underlying structures like the fascia. These nodules typically have a shell of fibrous tissue surrounding a center of fibrinoid necrosis. Between the necrotic center and the outer fibrous shell is what is known as a cellular palisade. It consists of densely packed layer of macrophages and fibroblasts arranged radially, rather like the arrangement of the seeds in a kiwi fruit. Further out, we have a zone that contains T cells and plasma cells. The most common approach is to treat the underlying rheumatoid arthritis with disease modifying drugs, DMARDs, which may cause nodules to shrink or resolve over time. Corticosteroid injections will be needed for larger lesions, which need to be injected directly into the nodule. Surgical removal will be required if the nodule is large, painful, or interferes with function. It is significant to note that these nodules can occur not only in the skin but also in the vessels, where early lesions show fibrinoid necrosis of the vessel wall with an inflammatory cell infiltrate, and later on the artery wall fibrosis with occlusion can appear in the large vessels. The nodules can occur in the lungs or heart, which will be dealt with a little later in this video. The presence of these nodules is usually rare in seronegative rheumatoid arthritis. But skin manifestations do not stop with the rheumatoid nodule. Other changes can also occur as a result of small vessel vasculitis that occurs, like splinter hemorrhages, periungual infarcts, and digital gangrene or ulcers on the leg due to Raynaud's phenomenon. Another very significant involvement of the skin in rheumatoid arthritis is the condition known as pyoderma gangrenosum. It is a rare disease characterized by chronic recurrent ulceration of non-infective origin and usually associated with rheumatoid arthritis. It is a circumscribed necrotizing vasculitis of unknown etiology. Although these lesions typically affect the lower limbs, they can affect the entire body. Rheumatoid arthritis can also affect the eyes and the ocular system. Like the joint, the sclera and cornea contain proteoglycans and collagen. So vasculitis, infiltration and fibrinoid necrosis can occur in these structures also. Clinically, the commonest presentations in the eye are the dry eye syndrome or the Sicca syndrome, episcleritis and scleritis. The most common manifestation of these, almost up to 10%, is the Sicca syndrome or keratoconjunctivitis sicca. It consists of dry mouth, eyes, nose and throat, which may cause what is known as the secondary Sjogren syndrome. This is caused by the meibomian gland, lacrimal gland, accessory lacrimal gland or goblet cell dysfunction. The symptoms are foreign body sensation in the eye, burning, decreased visual acuity, photophobia and sometimes severe itching in the eye. On examination of these eyes, we will note a less than 5 mm of tear extension on the Schirmer test, tear breakup time of 5 seconds or less, and decreased lacrimal lake which can be seen with staining with fluorescein or rose bengal dye. The treatment of the ocular manifestations in rheumatoid arthritis are usually symptomatic with artificial tear and or saliva supplements based on evaluation. Rheumatoid arthritis is a relative contraindication against refractive surgery, especially LASIK, due to its potential to exacerbate the dry eye syndrome. Scleritis can also occur in the eye in rheumatoid arthritis. Here there is inflammation of the sclera with vasodilatation of the superficial and deep episcleral vessels. It can be classified as anterior or posterior based on its position relative to the ora serrata. Anterior scleritis can be nodular, diffuse or necrotizing. It usually presents with intense pain amplified by eye movements, blurry vision, photophobia and tearing. The second type is the scleromalacia perforans, which describes anterior necrotizing scleritis without inflammation. This condition often presents without pain, despite its ability to lead to visual loss, astigmatism, and lobe perforation. Posterior scleritis is characterized by the T sign on B scan. This classic sign is produced by hyporeflectivity from both the optic nerve and the fluid under Tenon's capsule. Episcleritis is an inflammation of the episclera, which lies beneath the Tenon's capsule. It is bilateral in 40% of patients and is characterized by salmon pink eyes and mild pain. In contrast to scleritis, eye redness resolves with topical phenylephrine in these cases. Gastrointestinal manifestations are mostly iatrogenic and caused by medications. Rarely, mesenteric vasculitis can occur, leading to intestinal infarction. It is very rare but presents with acute abdominal pain leading to intestinal bleeding and perforation. Pulmonary manifestations of rheumatoid arthritis can either be pleural disease or interstitial lung disease. Pleural disease is said to occur in 50% of the cases of rheumatoid arthritis, with only 10% being clinically detected. Pleural effusions are usually exudates with mixed cell counts and high protein concentration. They are frequently associated with exudative pericarditis also. Pulmonary nodules, similar to the skin nodules that we have seen, may occur. They are usually asymptomatic, but they can cavitate and cause pleural effusions. As far as interstitial lung disease is concerned, clinically significant interstitial lung disease occurs in up to 10% of rheumatoid arthritis patients. Pulmonary fibrosis tends to occur more often in rheumatoid factor positive male patients. The most important cause of cardiovascular manifestations in rheumatoid arthritis is the occurrence of atherosclerosis. This can lead to accelerated cardiovascular events. The risk of myocardial infarction in female rheumatoid arthritis patients is twice that of women without rheumatoid arthritis, and in long-standing disease of at least 10 years, the risk becomes 3 times higher. Cardiovascular disease is the leading cause of death in rheumatoid arthritis patients. The other significant cardiac manifestation is pericarditis. Although symptomatic pericarditis is relatively uncommon, it has been seen that there is evidence of pericardial inflammation in 50% of the patients. It usually occurs in rheumatoid factor positive patients with nodules, and analysis of the pericardial fluid reveals changes similar to those found in rheumatoid pleural effusions. Myocarditis with the presence of rheumatoid nodules has been observed in autopsy studies, and myocardial fibrosis can lead to conduction abnormalities. Congestive heart failure may be more frequent than is clinically evident in rheumatoid arthritis. Endocarditis with formation of rheumatoid nodules in the aortic or mitral valves can lead to valvular dysfunction. The kidneys can also be affected in rheumatoid arthritis. Around 7 to 10% of rheumatoid arthritis patients have renal impairment, but it is not usually directly caused by rheumatoid arthritis. These are frequently the consequence of anti-rheumatic drugs itself, especially the NSAIDs and the DMARDs. Long duration of disease and poor response to therapy are important risk factors for development of renal manifestations of rheumatoid arthritis. The characteristic histological findings of kidney biopsies in rheumatoid arthritis may reveal a mesangial glomerulonephritis in 60% of the patients. This could be of two patterns: granular IgM deposits or granular IgA deposits. The second type of histological finding would be membranous nephropathy, and the occurrence of this is related to certain disease modifying anti-rheumatoid drugs that are being used. The third type of finding could be secondary amyloidosis, and this is usually seen when there is uncontrolled rheumatoid arthritis activity, high levels of pro-inflammatory cytokines, where serum amyloid A (SAA) then deposits in kidneys. Patients with rheumatoid arthritis may present with hematological abnormalities either at the time of diagnosis of rheumatoid arthritis itself or during the course of their illness. These manifestations can be in the form of anemia, neutropenia, thrombocytopenia or thrombocytosis, eosinophilia, lymphadenopathy, and Felty's syndrome. Of these, anemia is the most common. It could be caused by multifactorial disease activity. It could be drug induced, nutritional, or due to a GI bleed. Bone marrow suppression or ineffective erythropoiesis could also be the cause of anemia in rheumatoid arthritis. Typically, this anemia that occurs is normochromic, normocytic anemia. Felty's syndrome consists of the triad of rheumatoid arthritis with splenomegaly with neutropenia. It is usually associated with anemia and thrombocytopenia also. These findings, that is, splenomegaly, anemia, neutropenia, thrombocytopenia, and arthritis, can be remembered by the mnemonic SANTA, SANTA. Most of these patients have rheumatoid factor positivity, and in uncomplicated cases, treatment is mainly conservative with methotrexate. Splenectomy is a controversial option. We have seen quite a lot of the extra-articular manifestations of rheumatoid arthritis. But what is the frequency with which they are seen? A study done in 2023 showed that subcutaneous nodules, that is, the rheumatoid nodules, are seen in 8.3% of the patients, anemia is seen in 7% of the patients, and Sicca syndrome or the dry eye syndrome is seen in 5.8% of the patients. So it is important not to miss these extra-articular manifestations. We need to be particularly vigilant when there is persistently active rheumatoid arthritis, severe disease, high rheumatoid factor titers, and history of smoking, because these are the main risk factors for the patients developing extra-articular manifestations. For the management of rheumatoid arthritis, the advent and early usage of newer and more efficacious disease-modifying anti-rheumatic drugs are there. But for the extra-articular manifestations and preventing these extra-articular manifestations, there still remains a serious challenge to the rheumatologists, surgeons, and patients. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about the introduction to rheumatoid arthritis and the pathogenesis of rheumatoid arthritis. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, plastic surgery, trauma surgery, and ethics.